Dr. Horowitz is going to lead us in a state of the medicine conversation. So thank you, Dr. Horowitz.
So thank you to the organizers and to the Cohen Foundation for inviting me. I'm going to give you a talk on the state of medicine. And as a board-certified internist, and I told everyone yesterday I'm very proud to be a Mount Sinai graduate, so it's very nice to be here again. I'm very concerned, actually, about the state of health in our country. And I'd like to give you some sobering facts. 1 of every 2 adults in the United States suffers from a chronic condition. We spend $3.7 trillion on chronic disease. 87% of the deaths in this country and 70% of our healthcare costs are due to chronic disease. We're 26th in the world in life expectancy, yet we spend more money on chronic disease, and yet we don't have solutions. What we've been doing in medicine is we name diseases and we throw drugs at them instead of trying to find out exactly why people are sick. Now, that's not always the case, but as I'll show you in some of the chronic disease that are burdening our healthcare system, it's a real problem for us. My disclaimer on conflicts of interest is that the views expressed in this presentation definitely do not represent the views of the Tick-borne Disease Working Group, HHS, or the United States. I was driving in Connecticut just recently and took a picture of this, and I asked myself, really, who doesn't have Lyme in Connecticut when they're starting to actually name towns after people with Lyme disease? So Chester had Lyme, and Richard had Lyme, and Linda had Lyme. They're going to run out of signs after a while for the number of people with Lyme disease. So why are we getting sick? Well, the number of cases are increasing in part. You heard from Rick Osvald yesterday because of predators. There's less foxes, more white-footed mice. We're building homes in parcels near wooded areas. Ticks are emerging 2 to 3 weeks earlier. New species are emerging. And the types of ticks with different infections are spreading across the states and countries. And one of the ones that I think most of you are aware of is the Asian bush tick, which now has spread actually quite rapidly. And what's concerning is although they have not found as yet infections in the Asian bush tick, they do find severe fever and thrombocytopenia syndrome in Asia, which is a virus that looks like Ebola. We have to be very careful with tick prevention. And now they are starting to find also the Lone Star tick in Long Island, where people are getting alpha-gal allergy, which can lead to anaphylaxis. So we have to be very, very careful with tick prevention. The modes of tick-borne transmission are increasing. Borrelia miyamotoi is one of the first species with transovarial transmission and larval transmission. But we actually find the same problem with Poasan virus, with transovarial transmission, and I'll show you why that's a problem. The modes of human transmission are increasing. We can get them by blood transfusions, solid organ transplantation for like Babesia. Maternal fetal transmission, I'm very concerned about mothers in this country as far as passing on Lyme disease, Babesia, Bartonella, and other tick-borne infections. And of course, there's the big question as far as sexual transmission. And then we're finding these different infections, these different species of Borrelia, which we're not really accounting for all of them at this point, and co-infections in ticks. So if we look at the rising incidence of Borrelia infections, we found over 16 new infections and species in the last 30 years, which means roughly every 2 years we're finding another Borrelia species. And you can see at the bottom on the West Coast, Borrelia beseti and Borrelia lani were some that have been discovered in the last decade. These are newer Borrelia sensu species, apart from, as you just heard, relapsing fever, miyamotoi that's now increasing in California. So some of these pathogenic strains belonging to the B. burgdorferi sensu complex, they have a worldwide distribution, yet they're rarely considered or tested for, and the problem is all of the 2-tier testing we're using may not pick it up. We've talked extensively yesterday about why the tests lack adequate sensitivity, and I'll show you some slides on that. And regarding chronic diseases, what that leads to is improper diagnoses, chronic fatigue syndrome, fibromyalgia, autoimmune diseases, neuropsychiatric diseases with dementia. And this issue with persistence, it's always amazed me with the politics in medicine because when you look at the literature, and I'll show you a brief review of it, it does appear, at least to me, having seen 13,000 patients in 30 years, that this is a persistent infection. My patients get better when I put them back on antibiotics. And regarding the microbiome, I'll show you some of the studies, one which I did not discuss yesterday, of a shorter course of the dapsone combination therapy that is working in a 7-week protocol. That is actually, we've done a new study, and I'll be publishing it next year And finally, we find a lot of these other intracellular bacteria, and I'm going to talk about this in detail as far as I think where we're missing the mark in chronic disease, because there are over 36 different Bartonella species and subspecies, and we do not have the ability at this point to pick all of them up. And then you'll see in the study that the data mining study that we did just yesterday, we were picking up 16.5% of our patients with tularemia, 10% with brucella, and leading to chronic disease. In fact, with brucella, they found that 10% of the chronic fatigue patients in the Midwest were due to brucellosis. But if you ask most physicians, are they looking for these intracellular infections like tularemia and brucella, they're generally not. And of course, we have the problem with healthcare politics. So why are patients staying sick? So we learned in medical school Pasteur's postulate. And what I'd like to use to shift the paradigm for you is, instead of using this one cause, one disease model and the complexity that Dr. Chandra was talking about, is I believe we need to shift to a multifactorial model. So the study that I showed you yesterday was a 2-year study, a patient symptom survey and retrospective chart review. I actually sat myself and went through 657 volumes of charts, data mining and pulling out the data that I showed you to hopefully better define chronic Lyme disease, to evaluate the efficacy of dapsone combination therapy in those with chronic Lyme. And I will tell you that these persister drugs, where I got the idea from Dr. Zhang and from the great research that you've all been doing in the laboratory, they have been working much, much better, at least in my patient population, using these triple intracellular combos, and especially diagnosing abnormalities on the 16-point MSIDS map. So what I showed you yesterday is that, and this is really the key for this talk, if we want to get to the sources of chronic disease, infections and toxins are now linking up to many of the chronic illnesses that we're seeing. But you've got to get to the primary sources of illness. Most of these are chronic infections that we're seeing, for example, with tularemia and brucella and Bartonella. There definitely is dysbiosis. Prevotella species been associated with rheumatoid arthritis, Clostridium species with MS. Leaky gut can cause arthritis, along with food allergies, which stimulate the same inflammatory cytokine production that you get with Lyme. Sleep disorders raise interleukin-6, and as I'll show you in the autism population, these are some of the same cytokines that they're finding in the brains of autism spectrum disorder. And then we're exposed to over 116 different pollutants, according to the CDC study that was done in 2003, with nutritional deficiencies, so we can't handle the toxins getting into our body. And we are not generally accounting for the downstream effects: low testosterone, low adrenal function, neurological, psychological dysfunction, and in our patient population yesterday, over 40% with POTS dysautonomia. So if we took these 16 points on this MSIDS map, we can kind of condense it down to 7 factors. Rule number 1 for me is symptoms drive diagnosis and treatment. You heard from Dr. Chandra, if a patient comes in with day sweats, night sweats, chills, flushing, air hunger, I can't catch my breath, and a cough, and you've done a differential diagnosis, hyperthyroidism, tuberculosis, non-Hodgkin's lymphoma, malaria, menopause, anything that would cause drenching sweats, if those sweats are from Babesia testing positive, you've treated Babesia, the sweats come back, odds are you've got persistent babesiosis. But rule 2 is the most important, because if you don't lower inflammation, these patients will not get better, and one of the ways of doing it is detoxification. We have had patients come into our office with brain fog, and within 1 dose of IV glutathione, which is part of your liver pathway for detoxifying chemicals, the brain woke up. So there was a computer program in his 40s. He came to me a few years ago. He couldn't work for 2 years. First time in the office, after 2,000 milligrams of glutathione, within 15 minutes, his cognitive functioning was completely back. Now, I didn't treat him with antibiotics. I detoxified him. And that may be quinolinic acid and some of these environmental toxins causing problems. We need to repair the damage. That's the mitochondria. And when we're looking at chronic diseases, one thing that has been overlooked, mitochondrial disorders have been associated with chronic fatigue and fibromyalgia. They've been associated with ADHD, with autism, with Alzheimer's disease, with Parkinson's, with neuropsychiatric disorders. So mitochondrial function is being missed. We know about it, but it's not being used on a regular basis by internists when we're treating these people. We certainly don't always look at all of the hormones in Lyme disease, and we're finding for us 70% of the adrenals are off. And you have to, of course, get patients to sleep, get them off their allergic foods, sometimes gluten, exercise, and heal the emotional wounds. About a third of the women who come to me, when I ask them about abuse, physical abuse, emotional abuse, or sexual abuse, about 1/3 of the women tell me they have been abused. And I can tell you from working in over 30 years in this field, it's almost as if your immune system in these women will say, I don't deserve to get better. There's something wrong with me. You need to have a great psychiatric team on board with a psychologist and a psychiatrist to really get deep so that you're working the mind, body, and spirit in these patients. That is the way that you can get them better. So we're talking today about a personalized precision medical model. The people who come to see me, no two are exactly alike. One may have Bartonella, another may not. But what is certainly common among these patients is that they are presenting, many of them, with the diagnosis of chronic fatigue syndrome, with fibromyalgia, with these autoimmune illnesses like lupus and rheumatoid arthritis, despite the fact that they don't have the specific markers for lupus, like double-stranded DNA. They don't have CCP for rheumatoid arthritis, and yet they've been given Enbrel and Arava and prednisone by some of their doctors. MS is a particularly difficult one because of demyelination and how you can see Lyme and MS look very closely, almost exactly the same. And I'll show you some of the ways we differentiate it and some of the causes that's in the medical literature. So we have these great imitators, and what is the common denominator? Chronic fatigue, fibromyalgia, autoimmune disorders, neuropsychiatric disorders, and Lyme MSIDS share certain common clinical features. There's fatigue, there's widespread joint and muscle pain, there's memory concentration problems, there's sleep and mood disorders. This has been shown to be due to underlying inflammatory process and cytokine production with what I call the 3 I's: infections, inflammation, immune dysfunction, and it's been published in the literature, it's called the sickness syndrome, that if you get high levels of TNF-alpha, IL-1, IL-6, interferon gamma, these patients will get ill with these symptoms. So what is the consequences of this insensitive testing? Our national disability rates run between 13 and 19%. Chronic fatigue syndrome is 3.5% of the US population. Fibromyalgia is 1.5%. Autoimmune diseases are affecting over 23 million Americans, and all we've got at this point is basically using Plaquenil, methotrexate, Arava, Enbrel, instead of saying, could infections and toxins be driving some of these autoimmune processes? And certainly, as you heard from a psychiatric standpoint, they can cause a lot of psychiatric dysfunction. And as Bob Bransfield has pointed out, we have to be careful with suicide. Now, Judith McCloskey from Switzerland and other researchers have been publishing on spirochetes and Alzheimer's that have been showing up now for decades. And you heard about syphilis, which certainly has been known to cause dementia. So I'm going to show you at the end of this presentation some of the scientific literature at this point with some of the overlapping factors now that I think we need to look at regarding the Alzheimer's epidemic, because the recent studies are 46.5 million Americans have preclinical dementia. Now, I don't know if that kind of wakes you up a little bit, saying we are in a healthcare crisis, we've got a big problem here, that we've got a major epidemic of Alzheimer's, and none of the scientists or doctors are saying we know what's causing it. But actually, the scientific literature does give us some clues. So the problems with diagnostic testing, I don't need to go into a lot of the literature, but here's again 6 studies showing problems with the 2-tiered testing. You can see the same problems with testing for co-infections, whether it's Babesia, borrelia species, Bartonella, tularemia, or mycoplasma. And there was a study done by the New York State Department of Health 22 years ago where they showed that 81% of those patients who did not have an erythema migrans rash were not confirmed with 2-tiered testing. So that means 19%, right, of those patients with EM rash. Exactly the number I showed you yesterday. In our data mining study, 19% of our patients had EM rashes, 45% had IgM Western blots, which fits Nicole Baumgart's model in the mice, that there is basically the B cells are being subverted, there's T cell independence, you're starting to get more IgM antibodies. So Dr. Chandra was telling you about taking a history. That's what I do as an internist. 90% of all your diagnoses is by taking a proper clinical history. So we published this at the end of last year with the HMQ. And we found that there are 6 factors: neuropathy, cognitive dysfunction, musculoskeletal pain, fatigue, dysautonomia, and cardiorespiratory factors. These were the factors most significantly with Lyme. and especially the 5 factors was fatigue, flu-like symptoms, joint stiffness, tingling, that's neuropathy, concentration problems, and this was in 1,600 people from 3 medical practices. But the key was migratory pain. Migratory joint pain, migratory muscle pain, and especially migratory nerve pain. Migratory nerve pain is, again, the only thing you'll see it in is Lyme disease. I went through the literature in detail. This study showed convergent, divergent, and predictive validity. The discriminant analysis showed that there was an 87% accuracy of classifying someone as having Lyme, which was better than the 2-tier testing, which averages about 56%. And a score more than 63 was 2 standard deviations above the mean. And questions 1 and 22, which Dr. Chandra was talking about on the HMQ, indicate a possible co-infection with Babesia. So the healthcare politics, unfortunately, are insurers only accept positive 2-tier testing. Doc, can you see the problem? Yes, I'm afraid so. Now, I didn't show you this slide yesterday. I wanted to save it for this talk. Pat Smith, during the Tick-borne working group, said, gee, I think we ought to look and put the 31 and 34 band and get them reported on the Western blots. So we took 600 Western blots and we put every band on the Western blot into the database and ran the numbers. On the IgM Western blots, you'll notice that the 31 band was over 40% positive, and the 34 band, the OSB, was about 20%. These were not necessarily in patients who were 2-tiered positive. So as a physician, if you've not had the Lyme vaccine, if you've not had a recent viral infection, the 31, the OSB, and the 34 OSB are significant for exposure to borrelia. So if you have good and bad days with symptoms coming and going, and you've got cognitive issues, and you've done a differential diagnosis, and you've got a 31 or a 34 band show up without a vaccine or recent viral infection, that tells you there's a borrelia species. Not necessarily Burgdorferi, but certainly a borrelia species, and this argues that the commercial lab should be putting the 31 and 34 band. Let the doctors decide at this point in time that they want to ask the questions about vaccines or viruses. We didn't really talk about it much yesterday, but John and Mark Zalosky has done some really great work on chemokines. I asked them yesterday, why is it that the CXCL9 and 10 and CCL19, why do we not have that commercial test available for early Lyme before the antibodies are formed? And they said it was the valley of death. And I said, what is the valley of death? And it's like, well, that's where someone takes a look at what the financial implications are by putting this testing out. We're putting a financial cost on people's lives because the antibodies are not formed for weeks, but that study might show it. CXCL13 is a marker for acute neurological Lyme disease. How useful would that be in people that maybe they don't want to get a spinal tap? And CCL19 has been identified in late Lyme. And then we've got PCRs. We need direct testing. Nested PCRs have recently been shown where they have decreased inhibitors that they're equal to real-time PCRs. So we need to start expanding our diagnostic testing way beyond 2-tier testing if we're going to find what these patients actually have. And of course, the co-infections, as I explained to you yesterday, babesiosis was in 80% of these patients that we data mined. Bartonella was in 47%. And we need to expand the net because this is what showed up in these 200 patients when we looked at co-infections was quite a bit of Babesia Bartonella, but again, a smattering of brucella, tularemia, viruses, Q fever. Now, one virus that I did not look at was Poasan virus. This was just published last year that in Lyme endemic areas, Connie Knox showed that there was a serological evidence in 10.4%. The study that was published this year by Cope Laboratories and Connie Knox was up to 16% in her second study. This means if you're living in New York or Michigan and places in the US where there's a high Lyme endemic area, there's a very high risk of now getting Poasan. Now, 10% of these cases can be deadly. So please, again, going back to prevention, people are not looking for this, but it's going to start showing up in greater and greater quantity because, as I said to you, there's transovarial transmission. And regarding the state of medicine, again, in complex theory, here's 16 different factors that we found on the MSIDS abnormalities for 30 years looking at 13,000 people. And most of these infections that we see are persistent. I wanted to show you briefly the treatment failures due to persistence of Lyme borreliosis in fibroblasts of the skin, in the eyes, in the ligaments, in the joints, in the endothelial cells and macrophages, in the central nervous system. I think many people know the famous Vicki Logan case from Ken Liegner, where the CDC was involved in this and they found active infection in the central nervous system despite years of antibiotics. That's where I think persisters and biofilms are so important. And the biofilms that were discovered by Sappi and McDonald may even be accounting for some of the persistence we're seeing for some of these other ones. So you heard about the xenodiagnostic study, again, chronic persistent infection in mice, in the macaque monkey, and even in humans, right, in the Marquez study that was done by the NIH, one of those patients with PTLDS had a positive DNA result. And this was just published this year. Persistent borrelia infection by histology, PCR and culture, very similar to Monica Ember's work in the macaque monkey. And again, co-infections, Babesia, Bartonella, Ehrlichia, and anaplasma will cause immune dysfunction. So the retrospective study of 200 patients, we did show that 14.5% of the patients were PCR positive. We found a lot of Babesia that persisted with Bartonella, tularemia, Mycoplasma fermentans, which has been associated with neurocognitive and neurological deficits, and viruses like HHV6, which Joel will talk to you about, which is seen associated with Alzheimer's. So the common denominator is that multiple intracellular infections are causing inflammation and immune dysfunction, and a lot of these intracellular infections may be resistant to therapy and located in biofilms. So I think the hope for the Lyme community and for many of these chronic diseases is actually that we have not been looking adequately at biofilms. We know that you can get it in prosthesis, you can get it in rhinosinusitis and otitis media. And recently, borrelia biofilms have been associated with chlamydia species. This is a study that Eva Shappi just recently did. So it's more than just borrelia that's even showing up in the biofilms. We're finding some of these other intracellular infections. So we talked yesterday about the work that I've done, taking some of the great work that was done by Dr. Zhang from Hopkins, saying, hey, when I was at Sinai 34 years ago, I was treating HIV with MAI, Mycobacterium avium intracellulare, and TB, and I was using INH, rifampin, and pyrazinamide. And when I learned that borrelia was a persister bacteria, I said, you know, it would be really fascinating to look at using mycobacterium drugs with these biofilm busters to see what would happen. So one of the first studies we published 2 years ago are mycobacterium drugs effective for treatment-resistant Lyme, tick-borne co-infections, and autoimmune disease. This was a woman who had Beset syndrome. So this is an autoimmune disease with no known etiology. She failed 19 years worth of DMARD regimens by a rheumatologist, prednisone, methotrexate, Arava, Enbrel. You can see on her tongue these big ulcers. She had them all over her body. You can see in her hands she had granulomas with very swollen joints. When I gave her doxy, rifampin, and dapsone, all of a sudden, Bartonella titers turned positive with a positive VEGF. Tularemia titers went up fourfold and reactivated, and I sent her to an infectious disease doctor who confirmed it. And HHV6 titers reactivated fourfold, and we gave her pyrazinamide, the drug that Dr. Zhang talked to you about yesterday. For the first time in almost 20 years, she cleared up her besets. So when you look at Silk Road disease, an unknown autoimmune disease, I believe it's due to Bartonella, because we used intracellular drugs, bacterial drugs, to clear up an autoimmune disease. The biofilm barrier to treatment, these biofilms have been shown responsible for recalcitrance of many infections, C. diff, candida, endocarditis, and they've shown up to 1,000-fold decreases in antimicrobial susceptibility in biofilms. So we basically took the research from Hopkins. We use oregano. We took the research from Eva Shappi with stevia. We're using biocidin, and we're combining with mycobacterium drugs. And again, 2 years ago, I published the first study on dapsone as a novel persister drug. Why did I use it? Because they use it for leprosy, and dapsone has anti-malarial effects, it's anti-inflammatory, and it's a persister drug. The study I showed you yesterday, instead of 100 patients, is now 200 patients, and we looked at the paired sample t-tests. There was statistical significance for every one of the major Lyme symptoms: fatigue, pain, headaches, sleep problems. And what's really encouraging is I've not had to put an IV line with Rocephin in someone almost ever in the last year or two since I've discovered dapsone combination therapy. When you look in culture, you can see that the dapsone-doxy-rifampin combination, which is in the bottom in the middle, was the most effective at lowering biofilm mass. So really, when we're looking at getting patients better, immune deficiency, which I showed you yesterday, showed up in about 20% of our patients with low IgG. 7% had chronic variable immune deficiency. A 2018 study showed you need a robust B-cell response to get rapid resolution of Lyme, and that's the opposite of what we found in these patients who were multiply co-infected. And I published a study, a case study this year, that we improved chronic variable immune deficiency using embryonic stem cell therapy in a young man who had Lyme disease, who was failing IVIG. We gave him embryonic stem cells, and now his immunoglobulins are fine for the first time off IV immunoglobulin therapy. There's only 25 case reports that have been reported in the literature with either bone marrow transplantation or embryonic stem cells, and this is one that I put in the literature. So apart from treating these infections, inflammation, and immune dysfunction, you heard about the microbiome, balancing the hormones, getting him to sleep with IL-6, avoiding allergic sensitive foods which drive cytokines, treating the POTS dysautonomia, which causes the same symptoms as chronic Lyme but doesn't require antibiotics, and detoxifying people from all of these chemicals. Now, why detoxify? Look at the long-term health risks that are published in the medical literature. Miscarriage, fetal death, decreased birth weight, and other fetal developmental effects. Children, environmental toxins lower IQ and raise autism spectrum risk. In adults, it raises Parkinson and dementia risk and raises coronary artery disease. It raises autoimmune disease risk, cancer risk, risk of COPD, obesity, and diabetes, and toxins increase neuroinflammation through microglial activation in both children and adults. So we have to get to the primary sources of inflammation and treat the downstream effects. Infections, toxins, and inflammation have been linked up with Lyme. You heard about quinolinic acid. But infections, toxins, and inflammation have also been associated with MS. We've seen in the literature Lyme, chlamydia, pneumonia, and Epstein-Barr virus variants associated with MS. Mercury and toxins like bisphenol A and asbestos can cause demyelination and autoimmune disease. And low vitamin D has been associated with MS, with a high 125 to 25 hydroxy vitamin D ratio associated with intracellular infections. But also infections, toxins, and inflammation have been associated with autism. In the study by Kuhn, 44 out of 48 children with that OSP-A, OSP-B on their Western blots improved with antibiotics. UC California Davis showed us that if you have pesticides in your body, your risk of autism is higher. That same year at Harvard, they showed exposure in the womb to mercury, lead, manganese, methylene chloride, and diesel raise the risk of autism spectrum disorder. And it's shown that IL-6 elevations, same cytokine in Lyme, will cause autism-like behavior. What about ALS? Infections, toxins, and inflammation have been associated with ALS. Lyme can mimic ALS. Pesticide exposure now has been shown to significantly be associated with ALS, and heavy metal detoxification can help, where oxidative stress and neuroinflammation are causing it. And finally, infections, toxins, and inflammation have been associated with Alzheimer's. In the study that was published by Blank in 2014, 7 out of 20 patients with dementia had Lyme in their central nervous system. They stabilized or improved their cognitive status with antibiotics, but it was the infectious burden of viruses, CMV, herpes virus 1, Joel will talk to you about herpes virus 6 and 7, bacteria like B. burgdorferi, chlamydia pneumonia, Helicobacter pylori, a spirochetal bacteria, and even Porphyromonas gingivalis, which can be associated with gingivitis getting up into the brain. These have all been published in the literature with possible associations with Alzheimer's. And toxins, elevated pesticide levels were published in JAMA just recently, with the Framingham study showing if you have inflammation, higher risk of Alzheimer's. So infections and toxins increase those cells in your brain causing microglial activation. It's activated by these pro-inflammatory cytokines that can lead to neuronal cell death, Lyme disease patients have these level of cytokines, and they've been found under biofilms. And low-dose naltrexone, by the way, has been published to help stop microglial activation. So the Alzheimer's rates are doubling, and the question is increased amyloid production trying to combat bacteria and viruses present under the biofilms? Harvard neuroscientists like Dr. Tanzi think so. And if we want to change the trajectory of chronic disease in this country and Alzheimer's, which is doubling and which is going to be 765 billion by 2050, we've got to change the paradigm. So what is the paradigm? Oxidative stress and inflammation, when you look at the medical literature, underlie chronic illness. Whether you're talking about Alzheimer's or Parkinson's, heart attacks, rheumatoid arthritis, dermatitis, asthma, the one common denominator is free radical oxidative stress. So if we want to shift the problem and shift the paradigm for these chronic diseases that are burdening all of us in our healthcare society, we need to shift to a different model. Multiple infections and environmental toxins have been linked to autoimmune manifestations. They're known to cause inflammation with epigenetic changes. They're associated with immune dysfunction and deficiency, and they have these downstream effects like HPA axis dysfunction, affecting the mitochondria, autonomic neuropathy. The solution is we've got to get to the sources of inflammation. Some of it can be blocking NF-kappa B and nitric oxide, which cause these inflammatory cytokines to be produced. You have to work on detoxification and repairing the damage. So our prior present state of medicine, sorry, I can't heal you, you have a pre-existing condition. The future of medicine, shift the paradigm to a personalized precision multifactorial model. Laura, you have a rare condition called perfect health. Frankly, I'm not sure how to treat it. Thank you to Bay Area Lyme who helped sponsor this study, to my staff, and to everyone who has made this possible.